So it's my pride, privilege, and pleasure to present the introductory note about Dr. Armoogum Parsuramen. Obviously, his extensive laurels, achievements would take a long time to get mentioned. Hence, I make a simplified note for his introduction, for which I use a small PowerPoint presentation. Dr. Armoogum Parsuramen is born in 1951 in Mauritius, with his ancestral roots from Salem in Tamil Nadu, India. Mr. Parsuramen holds a BA Honours degree in administration from the University of Mauritius and started his career in the field of education as a secondary school teacher in 1978. With the blessings of his parents and strongly imbibing the ideologies of Mother Teresa, Mahatma Gandhi, and Tamil Saint Thiruvalluvar, he was serving the people of Mauritius as member of Mauritius Parliament from 1982 to 1995 and served for 4 consecutive terms, winning all the elections he contested as a much acclaimed political leader. He honorably provided excellent leadership as Minister of Education, Arts and Culture, and Minister of Education and Science. He has been credited with being the architect of Mauritian 10-year education master plan, which spearheaded the development of Mauritian education system. Mr. Parsuramen joined the World Bank in 1997 as Education Policy Advisor and Coordinator of the Education Component of the United Nations Special Initiative for Africa, administered by the World Bank. In 1998, he was appointed as Director of UNESCO's Division for the Renovation of Secondary and Vocational Education, and in 2000, he became the Director of same organization's Regional Bureau of Education in Africa. In 2004, at UNESCO headquarters in Paris, to lead both the Secretariat of UNESCO Executive Board and that of its governing bodies. In 2009, Mr. Parsuramen was appointed as Director of UNESCO, New Delhi office, and representative to Bhutan, India, Maldives, and Sri Lanka, where he served tirelessly till June of 2011, when he retired and returned home to Mauritius. Armoogum Parsuramen GOSK is currently the founder president of Global Rainbow Foundation, a charitable trust dedicated to the relief of poverty, the advancement of education, assistance to children with physical and mental abilities, and any other purpose beneficial to the public in general and the poor and disadvantaged. Since 2013, Mr. Parsuramen is also the founder president of University of Third Age Mauritius, and since 2018, founder president of International Thirukural Foundation. Dr. Parsuramen is a charismatic leader who is being loved and respected by political leaders, bureaucrats, and experts from various domains. Last year in 2019, the prestigious Tamil University at Tanjavur, Tamil Nadu, conferred him a D.Litt honorary degree for his great works on spreading the Thirukural and its values throughout the world. With our love and respect, we welcome you, sir, for the presidential address.
Yes, I've done that.
Yes, sir.
So, my very respected and good friend, Dr. Karthikeyan, Dr. Bara Murali, the head of Hamsa area, Miss Smruthi Venkat, and all the distinguished participants at this special webinar organized by the Hamsa area. I would like to extend a very warm welcome first, and thank to all of you for taking time to be with us on this webinar. And this webinar offered to Mauritius, but as well as Indian participants. I believe for us, it's a landmark in Mauritius to benefit from such a wonderful presentation and the experience and the knowledge. Let me also pay my greeting to Dr. Bara Murali, I've been meaning to call you to talk to you, but somehow it would have been taken up with other commitment, but I'm glad to meet you, to see you on screen. And I can already announce to you that Global Rainbow Foundation has reviewed, and Dr. Karthikeyan, we have reviewed the proposed MOU, and we are ready to go. We are ready to sign it. Today I'm giving you the official green light, and we will therefore sign the MOU with you so that Hamsa Rehab and the Global Rainbow Foundation, always with my good friend Dr. Karthikeyan, we will now launch in Mauritius the activity that you do, and we are looking forward to the collaboration, to the exchange in the context of the MOU. But more interestingly, I know because of COVID, I can't get you to come to Mauritius. Dr. Karthikeyan has been to Mauritius many times, but I would like to invite you officially, Dr. Baramurali.
Thank you, sir.
Once things cleared, you have to come to Mauritius. And on my side, I'm eagerly waiting for the frontiers to be open so that I can go back to my incredible India. That's where I'm stuck. Never have I stayed home so long, and never have not I've not had such a big gap from my last visit to India. So you could understand the affection, respect, and the high regards I have for India and its institution. I would also like to say that, let me also express appreciation and commend Ms. Smruthi Venkat, a very distinguished professional in her own field, in the field of neuro speech language pathologies. And you have demonstrated history of working in the hospital and healthcare industry. You are very skilled in research, organization skills, leadership, team building, and public speaking. With a budding interest in speech and language sciences, you have a bachelor's degree focused on audiology and speech language pathology from Manipal Academy of Higher Education. But more importantly, you have a very strong clinical judgment and strategic planning capabilities for assessment and diagnosis of diverse patient population. Being an adept at following up on patient plans and aims to provide best patient care with good communication and relation building skills, focusing on continuous advancing expertise in neurological patient care, and also special interest in aphasia and dysphagia rehabilitation. That's a very brief. I don't want to go through the whole, very prominent profile you have, but I would like to say that there is an invitation for you also, once the frontiers are open, to come to Mauritius.
Thank you, sir.
That's the only humble gift we can offer to our friends. Dr. Karthikeyan know that. And, but apart from that, let me say that thank you, Dr. Karthikeyan, for the very, very impressive presentation you made on me. I discovered a few things in your presentation that I didn't.
Thank you, sir. Thank you.
But now let's come back to the main, to the topic of today's webinar. Finding the voice of the brain injury, and here this is an area which is very critical. We have many cases in Mauritius, and Global Rainbow Foundation also deals with quite a number of cases, provide rehabilitation. And let me pay credit to Dr. Karthikeyan, who together with my manager of the Rehab Center, Mauritius, GRF, Ms. Sonia Fali Fokira, Mrs. Na Fokira, who have worked very closely to establish our rehabilitation center. It provides various services and so on. So we are looking forward to this webinar, to the presentation, and I'm sure this will now be the beginning of the long-term collaboration between Global Rainbow Foundation and Hamsa Rehab. As I said all the time, I have to say, together with Dr. Karthikeyan.
Yes.
So let me conclude with this brief introduction, brief comment, and we are very much looking forward to the presentation. We are also looking forward, the Mauritian team present have come. I'm very pleased that we have more than 100 participants, which is very significant for this webinar. And I would now, I won't keep you longer, but I leave you now for the presentation. Probably Dr. Karthikeyan will introduce,
Yes, sir.
and then we can start the webinar. And after that, there will be a session of question and answer
Yes, sir.
that will follow. Huh? Thank you.
Yes, sir.
Thank you, sir, very much. I think that was a nice talk, and we are very happy to associate with Global Rainbow Foundation. And it's so nice to know that you're also from Salem, and I'm also from Salem.
Oh, wonderful, wonderful.
Yeah, so
that's very good. I'm very happy to hear that, Doctor.
Yes, we will definitely come, and we look forward to your team also talking to us and
Absolutely.
sharing knowledge with us.
Absolutely.
Over to Dr. Karthikeyan. Thank you.
Yes.
Thank you very much.
Now I'd like to invite the speaker, the star of this session, Ms. Smruthi Venkat, a budding professional in the specialty of speech language pathology, who is associated with Hamsa Spine and Brain Rehab, well committed, disciplined, and passionate towards patient care, whose contributions in brain injury is commendable. Already, Dr. AP has given a very long, extensive mention about Smruthi. With all that, now I invite Smruthi Venkat for talk on finding the voice after the brain injury, update on speech language therapy. Over to Ms. Smruthi now.
Thank you so much, sir. Thank you. I shall begin the presentation. Can you see my screen? Okay, so I think you're able to see my screen. I thank Dr. Armoogum and Dr. Karthikeyan and Dr. Balamurali for providing me with this opportunity. So let's just get straight to it. Let's first, so this presentation is going to be moreover a clinical presentation on sharing my views on finding the voice after brain injury. So let's just explore the topic a little initially. So I'm sure whoever's joined this webinar is aware about the number of reasons that can cause the most complex organ in our body to disrupt it when it's function. So let's briefly go over the causes of brain injury. And before that, the agenda of today's presentation would try and get you thinking about your clinical practice in speech language pathology with a few case examples and an analysis of that, and introduce a few clinically useful methods for assessment, and maybe try and answer a few questions. So I'm just here to share my experience as a clinician in the past year with the 100-odd cases that I've seen of both brain injury and stroke. So briefly going over the causes of brain injury, all of you must know, and there may be varied causes of brain injury, which include vascular causes, trauma, toxicity, infection, be it iatrogenic, allergic or anoxic, or metabolic injury, neoplastic, which might include tumors, or degenerative causes or demyelinating causes. So why do we say, so are you saying something? I can't hear you.
Hello, Smruthi.
Yes, sir.
Sorry for the interruption. The audience wants to be a little louder.
Okay, sorry.
Okay. Thank you. Right.
Yeah, sorry. So these are the various causes of the brain injury, and why have we named the webinar Finding the Voice? So what do we mean by voice here? So all these disorders, all these causes of brain injury can affect your speech, language, and which is essentially comprising of your communication skills. So finding the voice here does not mean the scientific term voice, but in this context, it means sort of literally, your voice is your mode of expression. It is the way in which you communicate with the world, and it's basically your vocal fingerprint. So which brings me to my next question. If you had a choice, and if somebody comes up and asks you if you would rather keep your ability to walk and move around, or your ability to communicate, which one would you choose? As a speech language pathologist, as a communication pathologist, I would argue that the communication ability to communicate or express your views is essential, is extremely important. This is what differentiates us from other human beings. So our patients with brain injuries are not really provided this option or opportunity. They face something unexpected, which is brain injury, and they are left with a disability. So we are going to discuss in detail about disability in communication. So let's try and understand what communication is first to people who are not from this background. So let's compare the brain to a computer. So these are the components that you generally face when you see a computer, when you're using a computer. So first, reception. You're listening to me. You're listening to a webinar right now, and you're listening to me. You receive the information. And your brain constantly documents, continuously records what you're hearing. Then the network within your brain transfers the information from one area to another and searches in your existing database information in the already available database of your brain. It also includes clouds where memory, storage, you search for the particular words that I'm using and the words that you're hearing right now. And that's how you try and register, understand what I'm saying. And then if you have to reply to me, you try and think of what you want to reply. And that's the entire process of communication. So any disruption in any of these processes is going to cause a communication break. So for people these are the possible speech and language disorders that a patient might present with who has a brain injury. So what is speech? Speech is what you hear. It's the audible manifestation of language. And these are the few speech and language speech disorders that you would see: dysarthria, apraxia of speech, acquired neurogenic stuttering, neurogenic voice disorders, which might also be classified under dysarthria. I've just put it separately. And these are a few language disorders. So what I mean by language is the complex processes which we just explained and happens inside your brain. So you thinking, formulating the words, and using the right words to form the sentence essentially constitute language. So aphasia, dementia, right hemisphere damage, traumatic brain injury are a few language disorders that you might clinically see. So as a clinician, as a student of speech language pathology, during our studies, we study about all these different disorders separately. We study what their assessments are, what their interventions are. But the clinical scenario is sort of different, and that's what I've experienced this year. I know what intervention I have to give for an individual with aphasia, with an individual with dysarthria. But what happens in brain injury is that everything's organized in one compact structure. So when you are put in a clinical scenario, you find patients which have multiple deficits. They have aphasia, they have dysarthria, they have apraxia. So they have multiple deficits in the same person. So what is important in that kind of a situation is your clinical decision making. Decide on which is important, what you have to intervene first, where to begin. So these are certain questions that every clinician faces once they start practicing separately on their own. So the solution to this is your clinical assessment and the information you obtain from the clinical assessment. So as I've explored through this year, I think any communication profile would fit these three words, which is dynamic, different, and deceiving. So through the presentation, I'll talk about why I say these three things, and we'll, talk about it. So dynamic, what I mean by dynamic is that it's constantly changing. Communication is a behavior. It's not going to be the same. Different and based on the context, based on a person, based on the situation, based on what emotion you have, your communication is going to be different. Why I say deceiving is that you can get tricked by it. So not all processes, not all situations are the same, and you have to be prepared for such an event. So what I would say is that a clinician who comes up with a speech and language diagnosis in the first session or the first sitting is most probably ending to change his or her diagnosis later during the course of therapy. So assessment. So let's move on to our clinical assessment. Is there a necessity to change the focus? So what I feel is that a patient-oriented assessment is the need of the hour. We talk about the different test batteries that are available, the different tests that are available to, test language or speech or communication, swallowing for that matter. But how many of these assessments are patient-oriented? Is it okay for us to use one Western aphasia battery to test all individuals? Is that information that a WAB or a diagnostic, Boston diagnostic test provides, is that enough? And after hours of experience with patients, I believe that a patient-oriented assessment is important, and it's the need of the hour for our clinical practice. And why? Why is that? Why do we need to use a functional patient-based approach to, maximize our outcomes, maximize improvements, which is going to be patient-oriented? It's up to the individual's potential. You use those potentials and try and tap them. It also ensures that the individual and the family have a voice in what rehab you are providing them, and also to demonstrate to the payers that the value of the skilled service that you're providing them. So I'd like to demonstrate this through a patient example. So these would apply to any patient with a brain injury, irrespective of lesion type of speech and language status. So what we're going to discuss is very brief topics in the clinical aspect. It's not going to explain in detail on the procedures. We're just going to briefly discuss on the concepts in speech and language pathology with case examples. So case example 1. So you have a 67-year-old patient with multiple cavernomas. Okay, he had a right on-time bleed, and he's been admitted at the rehabilitation center. When he came to us, this was his speech and language condition after an assessment. He had moderate flaccid dysarthria and a severe dysphagia. He was on PEG feeds, and he had a tracheostomy, deflated, and with a fenestrated cannula. So as a clinician, when you see this sort of a picture, what would you think? I have a poll. I would request the audience to answer the poll. So what would you do in this clinical situation? Okay, thank you so much. So most of you have said functional assessments. So I guess that would be essential in a clinical situation, you're right. And these are some things that, I thought as a clinician initially. So after I assessed the case, this was the things that presented in my mind after a detailed assessment. So I have to improve his oromotor ability, improve his respiratory support for phonation, start on his intelligibility training, give a dietary modification, probably downsize the tracheostomy or try capping trials so that, we can try and get him to speak. But when I actually started talking to the patient, his view was a little different. And half of the time when you are a student clinician or you initially start practicing, you don't think of what the patient wants or what the patient is trying to, what he decides to do in this situation, because at the end of the day, it's his rehabilitation that we're talking about. So this is what the patient told me. So he asks me these questions: when will I stop coughing? So he has a tracheostomy, he's constantly coughing. So his question was, when will I stop coughing? When will I be able to hear my own voice? I have not heard it for the past 6 months. And when will people begin to understand me? I used to be an orator and nobody can understand me now. And when can I eat? So these are the dynamic questions that the patient wanted to ask. And it's constantly changing. From the day I met him till date, his goals have been changing on a weekly or sometimes a daily basis. With each improvement, his goals are different. So apart from what you plan for the patient, it's important you consider what the patient wants and what his goals for each step are. You consider the communicative goals of the patient. Otherwise, there's going to be a huge gap between what the patient wanted and what you are trying to do as a clinician. So unless you include the patient in the planning, you're not going to satisfy their needs. And one of the systems that already exists for this, which gives you a detailed analysis of the patient's conditions in various domains, is the ICF. And this is an example of a patient with aphasia. It's available online, the ICF format, and they've just done a brief example of how they do it. So the body structure and function, I'm not going into that because it has a lot of information that we already do clinically. Let's move on to the activities and participation and environmental and personal factors, and why it is important for us to consider those things more than what our body structure and function assessment provides us. So here they say that reduced participation in activities outside the home, difficulty engaging in reading activities of novels, newspapers, withdrawal from social interaction. So these are very specific to the patient, and this is what makes that person unique. So it's important for us to use that information and cater our rehabilitation or our speech and language therapy to his or her needs. You also consider the environmental and the personal factors of the patient, including his level of motivation, his desire for independence, his confidence with familiar or unfamiliar speakers, and the support of the family that's available. That's one main thing that needs to be present, to be able to communicate. If there's nobody to communicate with, who are they going to communicate to? So those are things that you need to consider during the time of assessment. We clinicians probably think about these things as we go on through their therapy, but it is important to think about these things during the time of assessment and plan your treatment accordingly. So this is what they have given. So you clinically reason for each domain, and you decide what goals might be appropriate for the patient. What are the activities most important to the patient, and or when he is going to be discharged, is that going to work in that discharged setting? So for this patient, they've decided that the long-term goal will be functional use of communication for social greetings and social etiquettes, short questions, simple sentences, and a few short-term goals for initial therapy. So this is one organized way to, assess your patient and give a holistic information about the patient. There are multiple other ways, not just ICF. You have a lot of other communication profiling available, and you can use what you feel is appropriate for your case, or as a clinician, what you would prefer in that situation. Going on to the next case study. So here's a 60-year-old patient. He's recently retired from a full-time job. He's socially very active. The history says that he was completely involved in interactions, communications on a daily basis. And as he was retired from his job, he suffered an MCA infarct on the left hemisphere of his brain. He was diagnosed to have expressive aphasia with apraxia of speech. And when he came to us, he was communicating in the word level. So what would you do in this kind of a clinical situation? There's another poll. So which part of the history or assessment of this patient would you feel is important in your therapy? What would you choose as a goal for him, or what would you work on first? All right, so most of you selected functional communication, and yes, that would be right, but almost only 18% of you thought about social skills. So the question is why? You want to work on his expressive skill, you want to work on his functional communication. That is right. That would be an initial goal so that he can start communicating at least on a daily basis. But when you see all those options, social skills was voted about 18%. And as I told you in the history, he was a socially very active person, and he feels extremely handicapped right now, being unable to socialize. He has a lot of difficulty doing that. And so how would you quantify that? How would you use a method to try and identify what his social networks were before the onset of aphasia? So there's a paper on social networks after the onset of aphasia. There's a precursor to this. I couldn't access that paper by the same author. So what they say is that social networks are the context for communication and life participation, and is extremely associated with adults' health, well-being, and longevity. So as people, as human beings, we want to communicate. We want to communicate with people around us. We want to communicate with our family, our friends, our colleagues, and that is our social network. So even if there's nobody around, we have social networking apps we have on our mobiles that we use to connect with people who are not around us. So it's the same for an individual with a communication disorder, be it speech, language, anything. It's important for us as clinicians to understand what the social network of that person was before and after the injury. So the social networking analysis is a method that is used, which is actually recently developing, and there are not many tools available as yet, but there are a few, which is social networks inventory, the friendship scale, and there's a pilot tool also, the survey of communication and social participation. And as communication pathologists, it's important for us to understand how a person communicates in different situations with different people. I'm not going to be the same with my friend or my boss or my colleague. It's going to be different. I'm not going to be communicating the same with each of them. And it's equally important to an individual with aphasia or any individual with a communication disorder to understand this dynamic, and who can understand it better if not the communication pathologist. So what the study says is that after a brain injury or a stroke, there is a shrinkage of social networks, and there is a reduced frequency of contact with partners after the onset of aphasia for the entire group, for obvious reasons, because they're not able to communicate, they're not able to express themselves. But it's important for us to analyze and understand the dynamic that's going on and how they communicate with each of those individuals. Sometimes it might not be possible to analyze the whole network because there'll be a lot of people, but at least the minimal number of people, you have to do it at the time of assessment. So the results confirm that clinicians should be concerned about potential reductions in social network and the social isolation that people with aphasia face. And I think this is true for most communication disorders as well, not just aphasia. If a patient is on a tracheostomy, if the patient is dysarthric and nobody is able to understand him, he or she will be extremely handicapped, and you will have to try and figure out a way to help them out in this domain. And this method would also be useful after your therapy, if you can reanalyze on how many of their social networks have come back. So I've done this for the patient who I told you about, the multiple cavernomas, who's admitted with us. He came in with a moderate dysarthria and nobody was able to understand him. He had a tracheostomy. So we put him on a speech valve initially, started training his speech, because the first question was, when will I hear my voice? So we had to do that for him. And at that point, he was talking to one person who was his daughter, and who could understand him fairly okay, but she was also not able to obtain all the information from what he was speaking. So speech and language therapy aimed at slowly bringing back his social network. And today he's able to communicate with his boss, with his colleagues who were not around for the past 6 months, and a far wider social network, which was his goal to do so. And he communicates with his family members and all that. So it's a very useful tool if you want to analyze what your patient's communication abilities are. So how do you get this profile? How do you get the right communication profile? How do we overcome the challenge of communication being dynamic and different in various situations? You're not going to be in all those situations. You're going to meet the patient in your clinical setup. You're going to do a diagnostic assessment, like I said, not in one session, preferably in multiple sessions. But how are we going to overcome the problem of communication being so dynamic or being different in different contexts? There's another poll. Sorry, just a minute. We'll move to the poll later. So, so how are we going to overcome this? So another method that is less frequently used but should be getting more attention is discourse analysis. And this is to target the deceiving part of communication. If you're going to profile the patient with one clinical session or one Western aphasia battery, you're not going to get enough information. You need to use a discourse analysis to try and get the essence of the whole communication profile of the patient. So who does this analysis? Who has to do this? So this has to be done for all patients by the speech language pathologist. And it's extremely important for us to understand communication behaviors in different settings. So discourse analysis can be of two types, which is monologic or interactive. So monologic analysis include descriptions, narratives, procedural or expository type of interactions. Descriptions as in you describe a feature of a place or a thing. Narratives, they either recite a story, made up story, or retelling a story that already exists. Procedurally explaining something like how I'm explaining with these slides, or how to make tea, or how you would make anything else. So that procedure. And expository is when you make an analysis in your head and you're trying to explain that, which is also what I'm doing now. So I have an idea in my head and I'm trying to explain to the rest of you on what those ideas are. Also interactive, which is conversation. So all these are important, and whichever is possible based on your patient's communication abilities, I think that have to be used in the appropriate clinical context. So factor in the context of communication in your results, and you will get a much more accurate result based on their functional communication abilities in different contexts. This is another case example. So I basically had to do a discourse analysis in different contextual settings for this patient in order to finalize her diagnosis. So an 18-year-old patient, she suffered a fall from a height and suffered multiple fractures on her lower limbs and a TBI. The TBI was not major. So surgical intervention was done for the lower limbs and the TBI was managed conservatively. So she was delirious, she was irritated after the surgery, but she was communicating verbally. And fourth day after the surgery, she had a seizure. And after the seizure, there was no verbal output, and she presented with a lot of cognitive deficits. So she was just using nonverbal gestures and imitation. So we began with her therapy. We started with cognitive behavioral therapy, and once her cognitive behavioral issues started coming down, we realized that she has severe apraxia of speech. So there was just one repetitive sound that she used to keep repeating, and her auditory comprehension seemed very poor. So I obviously used WAB to try and evaluate her, and a few other communication test batteries that are available, and all of it just said that auditory comprehension was very poor. And suddenly I just gave her a reading material, and her reading comprehension was good. So, and she was using, at this point, after behavioral therapy and all that, she started using single words for communication. So this is the profile. And there was no marked injury to any of the speech and language areas. So there was only very few lesions in the subcortex and on the corpus callosum. So there's no major speech and language areas that were affected. So in this kind of a clinical situation, what would you do? So later, when I kept assessing the patient and tried to understand what her diagnosis was and discussed with a few people, it turned out to be auditory agnosia. Right? So in this kind of a situation, what skills would you work on initially? What skills would you target first during therapy? All right, so there seems to be a tie between cognitive skills and auditory skills, which cognitive takes the lead. So, since initially she had deficits in attention, orientation, and yes, we also began with cognitive training. But what I felt is that in this clinical situation, her auditory skills actually needed more attention, because she had auditory agnosia and she was not able to understand anything that we were telling her. So cognitive training was just initially like how we do with kids. We were just getting her behavioral issues down and trying to get her to pay attention. But auditory attention also was severely impacted. So auditory comprehension was very poor because of the agnosia, which included both verbal and non-verbal skills. And the only thing her speech presented was severe apraxia of speech. So this case was extremely challenging to come up with the diagnosis. Initially, we had to do a lot of tests and then try and get her to pay attention, work on her auditory skills first, work on her speech skills simultaneously through reading, and then go on with higher processes. So currently she's able to communicate in sentence level, she's able to describe, she's having full discourse conversations with her parents, but her auditory skills are still affected. Not severely, she's able to do until word level, but at sentence levels with competing stimuli, with background noise, or with disintegrated stimuli, she still has a lot of problem. And this, if not analyzed in the different contexts, I would never have found this, because she was having a lot of difficulty at home in the presence of noise. She used to keep quiet when people were around her were talking. So what I'm trying to say is that you need to understand that the communication profile is different in different situations. Like I said, those 3Ds are extremely important for a clinician to understand and use as a process of assessment. So during your process, you have to think more than what you thought when you were a student. You basically go with a test, you do the test, and you don't think of what difficulties the patient might be facing in a different situation with a different person, or what kind of management might be required to target those deficits that exist in the different contexts. So I hope that you think about these 3Ds when you conduct your assessment for each patient and use that during your management. There are multiple other ways in which you can target these Ds to try and make your assessment progress more comprehensible, more effective, more functional towards the patient. So with Stephen Hawking's quote, I think I'd like to conclude. So he says this, and he was a great personality, like all of you know. And this is what he said about speech. He says that it's the modality we use to communicate our ideas and enable human beings to work together and build the impossible. So we as communication pathologists have the opportunity to try and help someone communicate better, contribute their part in this university, be it through your assessment or through your therapy or your clinical judgment skills. That is extremely essential, and to help the patient improve his or her functional abilities. And so, like he says, our greatest hopes could become reality in the future, where technology and other factors come into our area, and we help a lot of people communicate better and make sure that all our individuals with brain injury or stroke keep communicating. So thank you for listening, and I would love to learn more if anybody has any ideas in any of these clinical aspects. I've presented a very brief perspective of mine. There's not much knowledge to share. I need some more experience to do that, but yeah, so this is just one perspective of mine, and I hope it was interesting or informative to a certain extent.
Okay. Thank you, Smruthi. It was an excellent presentation highlighting the clinical problems. You have dealt in a nice way that you have made a little basis for the theories of speech and language, and it was nice presenting with clinical scenarios. I think the participants would appreciate the way you have presented. I would like to have questions from the participants. Either they can unmute their mic and present the question, or they can type in the chat box.
And if you allow me, Dr. Karthikeyan.
Yes, sir. Yes, sir. Please.
Let me also join you in commending Smruthi Venkat for a wonderful presentation, very profound, very insightful. I'm not a medical person, but I can understand, its practicality and the guidance provided. And I would leave, the other professionals to talk more in the medical term. And I'm sure my colleagues from Global Rainbow Foundation, physiotherapists, occupational therapists, psychologists and doctors who are following will certainly give their input, and as well as other Mauritians professionals present. So let's look forward to this wonderful exchange that will follow now, following the wonderful presentation of Smruthi. Thank you.
Yes, sir. So we are getting a lot of appreciations in the chat box mentioning about the presentation. That's very nice. Dr. Bala, do you have any questions?
Yes, I mean, more than me, I think we want the audience to ask, but maybe I can start off asking.
Yes.
One of the patients that Smruthi was discussing about was this 18-year-old girl. who had a kind of a brainstem stroke with seizures, and she had a lot of problems with her speech. And it was a challenge initially to get her to talk, but very quickly we noticed that she kind of turned around and she started to being more communicative. So one of the questions I wanted to ask you is that, your choice of questions that you had given, whether it's cognitive first or auditory, and I think, all of them have to be looked at the same time. But what do you say? I mean, I'm not a speech and I'm a neurosurgeon, but, I don't understand the more details. But for somebody with this specific kind of an speech problem, um, is it first that you need to get their auditory listening skills, their attention first, and then followed by their cognition has to improve in order to react, and then they start speaking, articulating? So how do you do that, and what do you focus? Probably this will help many other people there.
Yes, sir. So for her specifically, it was, like you said, a mixture of a lot of things. So it was a cognitive linguistic disorder where she had deficits in all aspects of cognitive and linguistic aspects except for her reading. So her reading was preserved and her writing was okay. She still had a lot of errors, but her speech was affected because she had a condition called apraxia of speech. That's exactly why she was not able to speak. So the planning and programming in her brain was sort of affected, hindering her speech. And her audition, which is the input. Basically, the input was affected because of the auditory agnosia and the lesions in her brain. So what the auditory agnosia does is basically block that channel, and we cannot get any information through to her through the auditory modality. So the only way is to get to her through the visual modality or reading. So she can get and gain all information through reading, and her reading comprehension was luckily good. So what we did was try and target her reading first and try and help her understand what is wrong and try and get to see what she can read and she can comprehend. So this is what we're going to do, this is what you have to do, all written instructions. And thanks to one of my friends, she gave me the idea to do that, and we were able to execute that and then slowly try and help her speech with reducing the apraxic behaviors. So we initially started reducing her apraxic behaviors, so at least her output is fine. So apraxia is something that affects the output. So once we at least half target the output, we could work more confidently on her auditory skills, which were primarily important for her communication. So her auditory skills had to be targeted if she had to understand anything that somebody was asking her, if somebody was telling her something. Until then, even her parents were instructed to give her written instructions, and she was not understanding why people are talking to her in written, because she still was not understanding that she's not actually able to decipher what she was hearing. So it was a very complex clinical situation, and we had to target multiple skills simultaneously. But luckily, she was very stimulable and very cooperative.
Thank you. Thank you. That's very good.
Uh, Smruthi, you have one question from our participant, Pavitra Palani. How the patient's seizure was controlled, and if recurrent seizures there will be a significant cognitive decline and verbal regression. Can you please elaborate on it? Thank you.
Yeah. So thank you for the question. She had actually only one seizure. So yes, I understand that multiple seizures will definitely cause further cognitive decline depending on the locus of the seizure, depending on the severity of the seizure. So I think I'd like to talk about another patient who didn't have a fall, but she had a condition called autoimmune encephalitis. So because of the condition, she had super refractory seizures, which were seizures which continuously prolonged for more than 24 hours. And it could not be controlled by any medications. That's the nature of the seizure. So they had to sedate her, intubate her for a period of 10 days. And when we were able to extubate her, she had a lot of cognitive deficits. Like you said, her MOCA score was around 2. 2 out of 30 was her MOCA score. She had a lot of cognitive deficits. Luckily for this patient, she had only one seizure. It was medically managed, and she's still on those seizure medications. It's been tapered down, and we were lucky on that aspect. But for the other patient, cognitive deficits were severe, and yes, for her, we had to target cognitive skills first. And since she was also quite young, she was a 14-year-old, and she also quickly improved with therapy. I'm not really sure about the medical management part of it, on what medications are given or were given for the seizure. But I can let you know if you're interested.
That is nice. Smruthi, we have another question from Renuka Muthu. Ma'am, how do we differentiate speech and language disorders?
Okay, so
Very simply asked, but it is a very big question. Right.
speech is what you basically are hearing. I'm talking to you, you listen to me, and that's speech. Whatever you hear from what I say is speech. So it's just my muscles are working and they're trying to put out the message. That's what is speech. Everything else, the thought, what words I have to use, which order to pick them in. If I'm going to speak the same thing in a jumbled way, you're not going to understand what I'm trying to tell you. So that all those process, information retrieval, storage, memory, transferring from one portion of the brain to the other, all that comes under language. It also includes auditory comprehension or decoding the message. So I'm talking to you, your brain has to decode what I'm saying. Otherwise, you're not going to understand what I'm telling you. So speech disorders are just to do with my output. Language disorders have to do everything with the processing that happens within the brain.
Yes, nicely explained. And we have one question from Kripa Elizabeth Santosh. Ma'am, could you please explain the strategies used to work on the 18 years old patient's auditory skills?
Okay, so initially we had to do, we actually required diagnostic testing to diagnose the auditory agnosia, but we weren't able to do that because she was not cooperative even for an X-ray. So making her to, undergo an ABR or an LLR was extremely difficult. It was not possible, so I couldn't get it done. Initially, I had to do the assessment on a subjective basis, starting with her auditory localization, lateralization, her discrimination skills, and she was not able to do any of them. The other test that I could do is a dichotic test, an English word test that we had developed back in college that I had used to try and understand what her auditory picture might essentially be. Another testing that we had done is testing with background noise, with the competing stimuli and with disintegrated stimuli. So you would have obviously heard of a test that we use for functional hearing loss. We present a lower intensity stimulus in 1 ear and a higher intensity stimulus in 1 ear. So if I say he is going to the shop, he is going to the shop. Each word comes in the other ear. So we're going to keep, we're going to keep doing that. And the same things were used for therapy. We're going to, we started at sound level training with nonverbal stimuli. She was not able to identify any of the nonverbal sounds. So started with nonverbal sounds, then went to discrimination at sound level. Typically how we would progress with a case of auditory training. That's how we went about it. Along with cognitive training, we kept making her do all those things. So currently she's at the competing stimuli level. So sentence level with background noise is what we're training her for.
Good. We have a compliment with a question from Ginny Sam. Thank you, Smruthi, for an informative presentation with clinical experience. Now the question is, how did you deal with counseling the family, and how well did the client cooperate with the treatment due to severe apraxia and the auditory issue that she was facing?
Yes, so for the family part of it. Luckily, the parents were very understanding. We just had to explain. I had to explain how she had both an input and an output problem, because they had a lot of problem communicating with her, since they were not able to understand what she was trying to tell them. She was not able to understand what they were trying. So I just had to explain the whole communicative picture with what is apraxia, what is agnosia to them, and they were very receptive to it, and they were ready to use more of written stimuli, use more of visual stimuli. I had given them a few pictures at home, and get to start communicating, like food cards, food pictures, where she can choose what she wants to say, and she can use that for communication. So that's how the counseling sessions went. And
Okay.
I've already spoken about the intervention. So
Okay, that's fine. And you have one question from Sri Lakshmi. For patient of 58 years old with severe cognitive linguistic deficits, what would you suggest for the management options?
okay, so again, a detailed assessment would be required for this. You have to tell me what cognitive linguistic deficits the person has, and his communication profile as a whole would decide his management options.
Okay, there is one a question from Pavitra Palani. Ma'am, you highlighted on social skills importance, and if the patient is having one word expression, there is a word distortion also in his speech. So his speech will be not the recognizable to the receiver. In that case, before social skills, his mean length of utterance and fluency should have improved, or social skills, or both hand in hand. Can you highlight on it? I think I have some problem in comprehending this question.
I got that. So you're saying
Okay.
the patient has only one word, and it's probably dysarthric, and nobody's able to understand what the patient is trying to say. So what is important here is the cause of the one word expression. Is it a language disorder? Is it an apraxia? Is it, you have to decide what kind of disorder it is. If it's a language disorder, yes, it is important for you to work on his language skills in order to further work on his social skills. If it's an apraxia of speech, you will have to target his speech behaviors so that his social skills or his fluency can improve. So the second part of the questions.
Yes, the second part of the question is one word expression will not be recognizable, and in that case, before social skills is mean length of utterance, and fluency should have improved, or social skills are both hand in hand.
Both hand in hand. So you will have to work holistically to try and improve. So social skills is basically the result. So on whatever you're going to do, his social skills is going to improve through that. So you try and target the things that you have to target, and make sure that the social skills are used. Like basically he's functionally communicating with those skills.
Okay, very good. There is one question from Vani. Can you brief out how did you incorporated cognitive behavior therapy in sessions? Thank you.
So
Incorporation of cognitive CBT, cognitive behavior therapy in sessions.
yes. So we actually it was a team management. We've included the psychologist, the occupational therapist, and I to try and integrate the cognitive behavioral therapy into our sessions. The expert on that is obviously the psychologist, who obviously headed by the psychiatrist which medications she was on. That's how the cognitive behavioral therapy was carried out. So it's always better to have an expert in the team and not do it on your own unless you're certified with cognitive behavioral therapy.
Okay, fine. There is one question from Eva D'Souza. Ms. Smruthi, how did you track the patient's progress with respect to the auditory agnosia? And how were you able to differentiate the progress in auditory and language skills?
Okay, so fortunately, she did not have any language deficits. So I did not have to differentiate between the auditory and the language skills for the second part of the question. She had only apraxia of speech. And to track the patient's progress with to track the patient's progress with the auditory agnosia, we had to do a lot of behavioral tests, and she's still not cooperative for an ABR or an LLR, which might not give us a lot of information at this point, but more to do with her functional communication. So the dichotic tests, which was very useful, the number of stimuli that she was able to identify, the number of stimuli she was able to identify with background noise, and overall her communication profile that we did, and along with the other MOCA and all those cognitive tests are basically verbal cognitive tests. You have to give the instruction and the patient will have to comprehend and follow. So if I'm doing a MOCA for that patient, initially she couldn't do anything because she was not able to comprehend or receive any auditory information. But at this stage, she's almost at about a 25 on MOCA because her auditory skills, yes, it's not a direct measure, but that was only possible in this clinical scenario, since she's not up for any other diagnostic formal testing.
Okay. I think your present answer, the present answer will address the questions coming now. Kindly explain in brief as how did you begin and work further for auditory agnosia?
So we've already answered that question.
Yes, that is what. Okay. Are there tests to diagnose apraxia of speech?
Yes, there are formal tests to diagnose apraxia of speech. You cannot do it just with listening to a speech sample. There is apraxia battery for adults. There is the KSPT, Kosman Speech Praxis Test for children, and there are a lot more materials that are available. So you can use any one of them to diagnose the apraxia of speech.
Okay. There is one question from Rajalakshmi. Ma'am, can you suggest clinically more effective tool for assessing cognitive skills formally?
There are a lot of formal assessments for cognitive skills. So cognitive batteries that are available. There are a lot of Indian batteries that are recently available. Most commonly easily available tools are MOCA, there is ACE, there are different versions of ACE. There's other cognitive linguistic batteries that the psychologist uses. You can always take help from them to try and integrate those batteries into your practice so that you can get a lot more information. There are also lobe specific tests. So frontal lobe, parietal, temporal, all those lobe specific tests are also available to which will give you a lot better picture if you're dealing with a cognitive linguistic case.
Very good. And there is, I think it's a final question. Just a minute. There is one question from Sri Lakshmi. At what stage of therapeutic management will you introduce a AAC, that's augmentative alternative communication, for patients who is not going to be benefiting from any of the management options? If so, what the factors needed to be considered?
Thank you for the elaborate question. And AAC, I believe, and I think it's the common belief now, or it should be the common belief now, can be integrated from step one of your management. It provides them an alternate means to communication. At no point should the patient be with no domain or no modality to communicate. If they have a skill that you can tap, it's good to provide an AAC initially. Try and integrate your therapy along with the AAC so that it would be effective. And factors, there are a lot of factors. There are individual factors, there are family support factors, there are contextual factors. A lot of factors need to be considered, and that would need an entire presentation separately. Good.
The one question from Varshini, I think this ID was used by Dr. AP. Can aphasia lead to dementia? One simple question, yes or no? That's it.
Third, depends. I mean, I can't say yes or no, but
yes.
Clinically, aphasia, I mean, it's not directly related to.
Okay. Then this question from Dr.Armoogum Parsuramen. Ms. Smruthi Venkat, is it possible to offer speech therapy treatment through telemedicine, especially in the context of COVID-19? Yes, that is what we are here, Hamsa. we are here.
A
Yes.
lot of domains have started up, so a lot of domains. It would also depend on the abilities of the patient. So how it's done in the Western population is that they have a social worker to help. So the social worker can go to the place, try and help us to communication behaviors better, and that would be an effective way to do it. It is
Yes.
possible, but depends on the patient's abilities. If they have a severe deficit in comprehension, it might not be possible, or if they have multiple deficits, they are on a tracheostomy, swallowing is affected, speech is affected, language is affected, might not be very effective, but worth a try.
Yes, there should be one qualified person who should liaison from the patient's end. And I think that would be the ideal way of taking things forward. I think we have come to the end. All the questions you have very well answered. Thank you, Smruthi. And okay, it was indeed a great academic session with lots of knowledge sharing. Thank you very much, and I should share the information that Smruthi is heading to Newcastle, UK for her higher studies very shortly. Best wishes on behalf of Hamsa, GRF, and all the participants. And making a formal vote of thanks, my sincere thanks to my role model, my mentor, my philosopher, Dr.Armoogum Parsuramen, founder, president, Global Rainbow Foundation, a great visionary and a good human being with values. Thanks to GRF team, Sonia, physiotherapist, for coordinating starting from the inception of, starting from the first, she was coordinating very patiently. My sincere thanks to GRF team, the other GRF team, Zoya, Pallavi, and all other ones who are there. Thanks to Hamsa team for your valuable contribution. I hope they don't mind if I don't mention their name for want of time. It was a very interesting, useful session, and I hope that the association between Hamsa and GRF would go a long way in clinical, academic, and research works, much to the benefit of the society, both in India and Mauritius. Thank you all. My best wishes on behalf of Hamsa and GRF to you all.
Before you conclude, Dr. Karthikeyan,
Yes, sir. Please, sir. Yes, sir.
You finish first, and then
yes, I have finished. My profuse thanks, sincere thanks to all of you. Please don't mind if I didn't mention their names. My heartfelt thanks for everyone who are behind this session, who have made this session a successful one with their time, efforts, and patient listening. Thank you all. Now it's your turn, sir.
Yeah, very briefly, because I think you will spend good time in this webinar. Just to join Dr. Karthikeyan to convey great appreciation for Smruthi Venkat and wish you successful, studies in UK very soon. Unfortunately, you may have to wait before going there now because of the situation of COVID. But in any case, it was a wonderful eye-opener for us here. Now, because we are, I must say, Global Rainbow Foundation had the serious constraint with regard to offering to our patients, to our person with speech therapy treatment, right? And recently we've started doing some telemedicine, and this is an area where with Dr. Balamurali and Karthikeyan, and we would like to explore that. For me, this is a great eye-opener. We are doing some telemedicine service with a few patients. Sonia is coordinating that, Sonia from my office. But would like to do more of it now because the demand is there and the service is very limited. We have very few, available speech therapists. And I would really like to give that top priority, and we'll work out the modalities. And let me conclude by saying to Dr. Balamurali, since we are family now, we come from Salem, both of us. I would like to, we should plan, Dr. Karthikeyan, another webinar, right? And we can choose other topics from your wide range expertise. But once on that occasion, we can sign our MOU of virtually official signature, and then that will be the next webinar will be the concrete will be done in the context of the official MOU between GRF and Hamsa Riyadh. Is that
Yes.
okay?
Yes, sir.
Very fine. Thank you, sir.
Thank you very much.
Thank you, sir. Congratulations again, Smruthi, and all the best.
Thank you.
And
sir.
as you said, sir, the current situation requires virtual consultations, virtual therapies, and we've already been doing that for the last 2 months or so. Both speech therapy, physiotherapy, occupational therapy, psychological counseling. So at various fronts, and it is again a new eye opener. I mean, we were not prepared for this before this, and we've never done it before the COVID. So the COVID has taught us a lot of new lessons, and I think even education webinars have gone a long way. I mean, if we didn't have COVID, probably the number of seminars and other things we would have, may not be less. We'd be just waiting to get a flight to come to Mauritius or to come to India. But this has broadened our opportunities, and we can sit at home and listen to some excellent talks. And we have a wide, experienced team of therapists at Hamsa, and also we can get other, interesting speakers from Chennai with, more experience. So I'm sure, it's a big, gate open now for us to connect. I suggest all the delegates who have been here to be in touch with us. We will update you about all these future activities, and please do participate. And, we want to really spread knowledge. And thank you again. And it's a real pleasure for us to, associated with your foundation. And I hope we grow together. Thank you. And good night.
Thank you very much.
Thank you, sir. Good night, sir.
Good night.
Good night. Thank you all. Good night.